Kim Leadbeater's terminally ill adults end-of-life bill, better known as the Assisted Suicide Bill, intends to allow adults in England and Wales deemed to be terminally ill and with less than 6 months to live to receive help to kill themselves. In November 2024, at what is called second reading, MPs voted by 330 to 275 in support of the principle of the bill. It then proceeded to committee, where first expert witnesses are selected to give evidence, and then committee members undertake line-by-line scrutiny of the bill. As that is only just underway, it's a good time to reflect on part one, the oral evidence sessions. With me to do that is our Head of Policy and Research, Dave Greatorex, and two very special guests, former palliative care doctor, Dr Gillian Wright, and eating disorder expert, Chelsea Roff. In recent weeks, both have been involved in giving expert evidence to politicians considering assisted suicide in the UK. Dr Wright at Holyrood, where MSP Liam MacArthur's assisted suicide bill is under the microscope, and Chelsea Roff at Westminster. Let's see them in action.
I think some of the professionals' concerns is that they do see people change their mind, and that with not huge interventions, you can allay those anxieties in different ways. I guess that's my concern, is that highlights how much people find this a difficult and anxious time. And I suppose I feel that just to give them the means to take their own life seems, perhaps we should be able to do better than that, you know.
The question before you is, could this bill have knock-on effects that affect some of your most vulnerable constituents? And how many deaths are you okay with? That's really, if the safeguards fail once, that is a human being who maybe in a despairing moment was handed a lethal medication instead of the care and the treatment and the health they need. That's what we're talking about.
Gillian, Chelsea, thank you both very much for making time to speak to us today. But Dave, let me start with you. Before we go any further, let's help people understand where we are in the process of this bill's passage, or not, we hope, through Parliament.
So as you said, second reading was back there in November, and after that the committee was appointed, largely by Kim Leadbeater herself. There was a call for evidence issued finally at the start of January, and then the committee began meeting in earnest on the 21st of January, and they took evidence over 3 days, very condensed process. There were sort of 50 witnesses over 3 days at the back end of January 28th, 29th and 30th. The committee itself, there were 23 members of the committee, and 14 of them voted for the bill at second reading and 9 voted against it. That's a 60-40 split, whereas the vote at second reading was more like 55-45, so it's weighted in favour, disproportionately in favour of those who supported the bill. And part of that is the fact there are 2 ministers on the committee, which is slightly unusual, and both of those ministers, government ministers, voted for the bill, despite the fact the government is adopting officially a neutral stance. So there's that bias built into the committee, and that's been reflected in the evidence that they've taken as well. A disproportionate number of the witnesses were in favour of the legislation, particularly the international witnesses. Every single one of the international witnesses that was called to give oral evidence supports this legislation. Even the committee members, the MPs, I think all of the medically qualified MPs that are on the committee voted in favour of the legislation. Many of the most significant, in terms of experience and longevity in Parliament, opponents of the bill were overlooked for membership of the committee. So it just feels as though the process has not been conducted in an open and transparent and fair way.
And what comes after this stage?
So they've started, as you mentioned, the line-by-line scrutiny. So this is where they are going through the bill, looking at it in detail, hopefully in the context of the evidence they've received. That evidence is not just the oral evidence. They've also had written submissions, and we know there's been hundreds of written submissions, and MPs are already saying we don't have the time to get on top of all these submissions we've been receiving, but they're supposed to be considering the bill in light of that evidence. And there are lots of amendments that have been tabled as well. That's already well over 350 amendments that have been tabled. So again, how is there possibly going to be enough time in this committee to consider all of those amendments. Kim Leadbeater is going to take out the judicial oversight element of the bill.
Turn it into a panel.
Exactly.
She's called it Judge Plus, but it does seem to be taking out the judge.
That's right.
Which is,
Yes, so it's Judge Minus, really. Yeah, they've taken the judge away. We know that dozens of MPs expressly mentioned that judicial oversight element as something that convinced them at second reading to support the bill. So it's a significant change to be made by these 23 members of the committee.
And what comes after committee?
It goes back to, there will be opportunity for all MPs to consider the bill. It goes back to the floor of the House of Commons for report, third reading. And so all MPs will need to be considering just what has been changed in the bill and whether that changes the position they took at second reading.
Okay, so just to recap some of that, because as you say, procedurally it has proved to be very controversial. A stack committee in terms of the MPs sitting on that and what we know their views were. The selection of witnesses and their leaning in towards being in favour of the bill. There was a controversy around the not including initially the Royal College of Psychiatrists. There was concerns that there was not very good representation from disability groups. That was just at the oral evidence stage.
Yeah.
And then MPs haven't been able to, they've begun line-by-line scrutiny without having seen all the written submissions, written evidence submissions. They've begun it without seeing some of the most significant amendments, of which one you've mentioned there. And time has been a big thing. So at the oral evidence stage, people were constantly reminded, witnesses were, if not quite cut off, they had lot of restrictions on their time. The people tasked with scrutinising were told that they didn't have sufficient time to ask questions. Questions were limited. None of this adds up to a well scrutinised bill, does it?
No, that's right. No, and as you say, it was a recurring theme from the chair throughout the oral evidence sessions that we only have an hour for this session, or only half an hour left. Please, can members restrict themselves to one question and one answer from the witnesses? And it just really, it's no way to legislate on any issue, but particularly an issue of this significance.
And is the controversy having an impact, do we think, on MPs' voting intentions?
It certainly is. I mean, the press has been full of reports in recent days of growing discontent, even amongst those who voted in favour of the bill at second reading. People feeling that, particularly with the judicial element being removed, that they really voted under false pretences and they no longer feel that they're going to be able to support it at third reading.
Something like 60 MPs, if memory serves, quoted in their speeches, and not everybody got to speak.
That's right.
At second reading, but something like 60 referenced this as being a safeguard. Now, we always had problems with it ever really being termed as a significant safeguard, but even then, it's a safeguard that's been removed. And they're right, aren't they, to be concerned, to be angry, to feel like the whole substance of how this bill was presented, the safest.
Yep.
Kim Leadbeater was calling it out as one of the most significant safeguards. Kit Mulhouse was calling it out as one of the most significant safeguards, and we're barely partway through the process, and that apparent safeguard is already gone.
Yeah, that's right. And one of the MPs in the media specifically said, the judicial safeguard, so-called, was repeatedly cited to reassure those of us that had doubts. And now we're seeing that being removed.
In fact, I think there's a video circulating on social media which clips all of those, that repetition together, which is definitely worth watching. Well, thanks, Dave. Chelsea, I want to turn to you first, if I may. So we saw you in action at the Westminster Committee. Your expertise is in the area of anorexia and other eating disorders. And you spoke about, or what you were speaking about there was in the context of that in that earlier clip that we saw. But people might be thinking this is called the Terminally Ill Adults End of Life Bill. Anorexia isn't a terminal illness. What were you doing there? How do you answer that?
I ask myself that question every day that I work on this issue. You would be forgiven for thinking that, and I would say that I agree with you. Anorexia and any eating disorder should not be considered a terminal illness. But I think eating disorders have, in some ways, become the canary in the coal mine. With assisted death around the world, in that they expose how safeguards that sound very rigorous on paper become very slippery in practice. So I was invited to speak to the committee because earlier this year, or last year, we published a systematic review, which is a scientific study that looks at all the evidence available, not just in the scientific literature, but in government records. And we were able to document 60 women with eating disorders who had been assisted in death internationally. And I should emphasize that we think that is very likely an underestimate because there were so many countries where we couldn't even look at the data and confirm or rule out cases. But most important for the committee and most surprising to us as researchers was that this included 3 states in the United States. So in Oregon, California, and Colorado, where assisted suicide is only legal for terminal conditions, oversight agencies confirmed that women with anorexia had died by assisted death, and they didn't have co-occurring terminal conditions. It was for anorexia and for specifically the physical complications of their illness that their doctors argued that they qualified.
So this is really important because the slippery slope terminology is often dismissed. In fact, you were more or less dismissed. I think, I'm not sure quite to your face, but in terms of your data was dismissed as sort of being 1 or 2 or 2 or 3 or something, when clearly your study shows something different. But this is a very real example of how, when this door is opened, all sorts of people get caught, and yes, it's really important that people appreciate this. I think diabetes has also been talked about in a similar vein as being an area where people would be horrified to think it would be described as a terminal illness, but there are circumstances under which that would qualify.
Indeed, I would say that, if you look at just the annual reports in Oregon, diabetes, anorexia nervosa, HIV, and hernias are all listed as qualifying terminal conditions that led to individuals' assisted suicides, and that's in public reports. So we've seen that increasingly in countries that have tried to restrict this to terminal illness. And it happens through the interpretation of the law, not just through legal amendments. So often people express fears, well, what if an amendment is passed later and it opens it up to more people? And I would say that it doesn't even require that. If the words on the page aren't watertight, which they rarely are, they can be reinterpreted to apply to a whole host of conditions.
Yeah, and it just goes to show, Oregon is held up as one of these places where, which, it's a myth that that there hasn't been creep there, of course, because conditions have changed there as well. But it just goes to show, once the door is open, that the safeguards that are presented really aren't safeguards at all. Gillian, let me turn to you. Gillian, as well as being a former palliative care doctor, you also speak for Our Duty of Care, an organisation that represents doctors opposed to assisted suicide. The clip that we saw of you was from Holyrood. Now, in this session, we're largely going to be speaking about the Leadbeater bill at Westminster. But I just wonder if briefly you could give people a sense of just how similar the proposals from Liam MacArthur MSP are. They may not even be aware. There's lots of attention around what's going on at Westminster, and perhaps outside of Scotland, less attention is being paid to what Liam MacArthur is doing. Can you just take us through some of the similarities there?
Yeah, thank you. Yes, we have had a bill to introduce assisted dying in Scotland now for over a year. It was lodged, and then there has been a public consultation. So the process is different, and there has been quite a significant amount of press coverage, certainly in Scotland, and consultation about it. But it was, I guess it is different in that the bill is just for those who are terminally ill. So there's no 6-month criterion. And also it's permitted for those who are 16 and over. So that's different. There are similarities. It is still a 2-doctor model, but there's an expectation that it would be the person's usual GP that would do that. So there have been some real concerns that it's a broader bill than you might be seeing in England and Wales, and there hasn't been, for example, the judge oversight that there was going to be, probably for practical reasons as well. So I think it has been a slightly different process. We're yet to have our first vote. So the first vote was in November for the Leadbeater bill, and we're expecting that. But we're also at the committee stage, so it's just a slightly different process. And so there has been quite a significant amount of evidence from other countries, from psychiatrists, from Royal College of General Practice, about the bill, and a number of concerns have been raised, particularly about assessing capacity, about coercion, and similarities to what you've found in England and Wales as well.
Okay, you made some really good points there, Gillian, which we'll pick up on again in just a few moments. But just to say that if you are on our mailing list and you're in Scotland, then we will, of course, have already been keeping you informed about what's going on with the MacArthur Bill, and we'll continue to do that as it progresses. But let's just turn back to Westminster then, with nearly 50 witnesses and hours of evidence. There are any number of discussion points that we could raise now. The hit and miss nature of diagnosing someone with only 6 months to live, detecting coercion, assessing capacity, as Gillian just touched on there, the lack of conscience protection, the impact on some disabled people, those with diabetes and anorexia, as we've heard from Chelsea, the lack of any requirement for the judge, or possibly now we're hearing a panel to hear from patient's family or even the patient itself when making their assessments. Could spend a long time talking about any of that, and feel free to touch on any of those points at any point. But I've just picked out 3 clips from the oral evidence sessions, and I'm really just looking for your response to them. And then if we have enough time, we might speak a bit more generally about some of the other problems with the bill. The first one is from an Australian MP, Alex Greenwich. Very quick one.
Voluntary assisted dying in New South Wales is an important form of suicide prevention.
Voluntary assisted suicide, or assisted dying as he calls it, is an important form of suicide prevention. Assisted suicide prevents suicide, says this Australian MP. I think that's going to jar with a lot of people. I think they're going to think, well, how does that work? Tell us, what does that mean?
My initial reaction to that is just the importance of language. And so I think one of the key issues to this debate is that people understand what we're talking about. So when we talk to patients, it's really important that they understand what you're saying, and you use words that are clear and that you're not misleading. And I think that one of the real problems with this debate is that assisted dying is assisted suicide, and it's really important that everybody understands that. It's not a form of palliative care. It's not a variation on what we do normally. It's not stopping medical treatment. It is very clearly the doctor prescribing lethal medication that the patient then takes with the intent of ending their life. And so I think that's my kind of first reaction, is that people need to be very clear of what it is we're talking about. I think that what he's probably
Gillian,
getting at...
Just to interrupt you there briefly, just pick up on this point about language. I mean, Kim Leadbeater has repeatedly, and I think others have as well in the second reading, made this point that they want people to not use the term assisted suicide, don't they? Because this bill makes changes to the 1961 Suicide Act, but they don't like that language, do they? So this is to use the term assisted dying is essentially a campaign technique, isn't it?
Well, I would be concerned that the patients don't know what that is, and I think there's polling to support that. That some patients think, some members of the general public think that it means palliative care, that it means stopping treatment, that it means perhaps DNA CPR, don't resuscitate. And so I think it's really important that we are absolutely transparent in what we talk about, and I think what he's probably getting at is that there are genuine concerns that when people are terminally ill, there are people who take their own lives, and that's absolutely tragic and distressing for all of us to know that. And I think what he's saying that instead of those, what we're hoping to have is those who would be helped to take their own life. But I there's really important to establish that the evidence doesn't necessarily hold that to be true. So in countries such as Oregon, you don't necessarily see a reduction in the actual suicide rate. In Oregon, actually, it's gone up, and that's not necessarily a causation. There might be many other reasons for that. But it's not a direct relationship, and I think it's really important to establish that.
I couldn't agree more. And I also, agree with your note on the almost Orwellian use of language in this debate. And I think it's both confusing to patients, but also being used to shape public opinion. Um, I, I'm struck by some MPs' real resistance to that term assisted suicide, especially given in the bill before Westminster, there's no requirement that a person who is terminally ill and showing signs of a mental disorder be referred for a mental health assessment. So in
Mm.
Oregon, California, Washington, almost every U.S. state where this is legal, that's a requirement. This bill has been held up as having the most rigorous safeguards in the world, and yet that safeguard to assess the mental health state of the person requesting a lethal cocktail to end their life is notably missing. And I have to wonder if that was a choice, because I would assume that the framers of the bill would have reviewed other legislation and picked and chosen what they wanted to keep. Um, I worry about the erosion of suicide prevention in those
Yeah.
jurisdictions that have legalized this practice, and I've seen it. I've seen it with anorexia nervosa, where we see physicians saying, this young woman in her 20s, a third of the people the cases that we looked at were young women in their teens and 20s, and we saw physicians saying she has a severe and enduring form of the disorder. It's reached a terminal stage, and the best thing we can do is keep her comfortable and give her lethal medications to end her life. That is an erosion of suicide prevention in a population that is second leading cause of death in eating disorders is suicide. So we've seen that happen in eating disorders, and outside of, I think people who have more, classic terminal conditions also deserve mental health support when they have those thoughts and feelings come up. And I worry that that's being eroded.
I was just going to echo that, in that I think that was one of the real concerns that psychiatrists had when they weren't called initially. Yeah, I think you mentioned that the College of Psychiatrists wasn't invited initially to give evidence as oral witnesses, and I think part of the concern about was that they feel their role is in suicide prevention, and the whole support of those who might have of ongoing suicidal thoughts, and to not invite them to take part was to ignore or to undermine their expertise in this day-to-day practice of preventing suicide. So that tension of support, of encouraging some suicide but preventing others, is really coming to the fore, and we need to grapple with that. What does that mean in terms of this bill?
We touched on capacity a little bit there, and how people can have impaired capacity. And during the day one of the line-by-line scrutiny that happened last week, an amendment to try and deal with this idea of capacity and capacity not being sufficient, particularly where the capacity is impaired or may be impaired for other reasons, that was defeated. But let me we've talked about the impact on suicide prevention. Dave, let's just draw that a little bit more widely, because he didn't refer to it, but we know that there is an impact on palliative care as well, in the sense of funding for assisted suicide sees palliative care financing increase by less than without these kind of laws.
That's right, and I believe it was in New South Wales actually that a particular increase in palliative care was promised. At the same time, I think that assisted suicide was being introduced, but that level of leaping funding has not been forthcoming. It was cut subsequently, and the concern amongst many of the palliative care experts in this country, I think, is that particularly if it's an NHS service, that this assisted suicide scheme will be how it will operate, then it's going to be challenging for the same resources.
Yeah.
The same limited resources.
Which is inevitable, isn't it? How could it be any different?
So the implications for resourcing of palliative care are obviously significant.
Yeah. Let's move on to the next clip. This is Dr. Ciarán of End of Life Washington. Let's hear what she has to say.
Whether or not I think, the wanting to avoid being, quote unquote, a burden to a family member or to a caregiving team is a valid reason to pursue this. Yes, I think that is a valid reason amongst many for people who have a value system that highly orders that.
So, feeling like you're a burden is a valid reason to qualify or to apply for assisted suicide. That sounds tragic to me.
Yeah, I indeed, and we see this in the data in Oregon and in the very few jurisdictions that do track the reasons that people request lethal medications to end their life. We see perceived burdensomeness on others as a very as a highly cited reason. I want to go back and connect it to something you mentioned around mental capacity, though, because I think what I've seen in the committee is a real confusion between mental capacity and mental health. Mental capacity is not the same as mental health. A person can be severely depressed, they can have a personality disorder, they can have an eating disorder, and still have capacity to make particular decisions. One of the things I wish had come across more strongly when I gave evidence is that in 100% of the cases that we reviewed where women with anorexia were helped to die, doctors found that they had capacity to make this life-ending decision. And it's that really should show you how inadequate capacity is as a safeguard for this type of decision. So when I hear about people feeling like a burden and not driving their wish to die, I worry that what we've said are safeguards are really not enough to catch people that are clearly in distress and perhaps exhausted from many years of trying to get the treatment they need, or financial stress, or lack of access to housing. And I worry that autonomy has become this sort of beacon in our society, and we go, oh well, if the person is expressing their autonomy, we must follow it. And I've said before, when a young woman who's self-harming walks into a psychiatric hospital, no one thinks it's a good idea to put her in a room with self-objects and respect her autonomous choice to continue hurting herself. We recognize that autonomy must be balanced with other ethical principles. So I worry that autonomy has become far too central in this conversation, and we've forgotten about other ethical responsibilities healthcare providers have to their patients.
It's probably just worth saying, and Gillian, I don't know if you could speak to this, but last week there was quite a number of people picked up on essentially the low threshold that exists in the Mental Capacity Act, and which Chelsea has just articulated really well there. Do you just want to? Can you explain in layman's terms the significance of that threshold?
Well, I mean, the Mental Capacity Act it really means that you are being assessed on the ability to make a decision with how able you are to make a particular decision. So some people might have capacity, for example, to do certain simple things like choose what they would like for breakfast, or what they would like to wear that day, but they might not have capacity to write a will, for example, and that would require a really high level of cognitive function. And uh, what we, I think, have struggled with is that what came out through a number of the evidence sessions was that doctors do have experience in assessing capacity, but not necessarily in these very high level decisions. And so when it's the examples that maybe Chelsea was discussing there, they would be involving a psychiatrist, for example, and making quite a complex and subtle assessment of somebody's capacity to make that decision. But Chelsea's absolutely right in that that's quite different from their mental state. And I think one of the things that really came across, particularly in some of the psychiatrists' evidence, was that there's not a requirement to assess someone's mental state. What is their thinking? What is their psychosocial situation? Have they other thoughts? Do they have psychotic thoughts at the same time? What is the rigor of the assessment that's going on? And it's really really concerning that clinicians are looking onto this and thinking, where are these requirements? And going back, I suppose, to your original question, feeling a burden or feeling, hopeless, they can be markers of depression. They can be really concerning markers that people are feeling worthless or hopeless, and that there might be a treatable aspect to this illness. It might not be as much as a severe depressive episode, but it might be what a general practitioner might call low mood, and treat with an antidepressant. And I guess I'm concerned as a previous clinician, thinking that it might take weeks or perhaps months to see an effect from an antidepressant, and yet people might be funneled into an assisted dying pathway. And also, we're so conscious that services are not providing the right care at the moment. So we know that 1 in 4 people don't get access to palliative care. So they may well feel a burden on their families because they are possibly doing so much for them, and that there aren't the services to give those families a rest or a break. There's not the hospice bed when they need it. So actually, it probably reflects back on us as a society. What will we do when people are in great need? Do we just give them the means to take their own life? Or do we step up and say, actually, these patients and families need really good, comprehensive palliative care, social care, psychological support at all stages of their illness, not just, too little too late, which is what we're probably doing at the moment.
Yeah, and as you articulated just so powerfully in your evidence at Holyrood, we must do better. We ought to be able to do better than just saying, well, you're, dare I say, inconvenient or a burden. Even if you feel a burden yourself, will push you down this pathway. I mean, Diane Abbott at Second Reading Day spoke very powerfully, I think, about this sense of feeling a burden to family, sense of feeling that there being a financial burden, or just the pressure from yourself.
Yep.
And she said, if I remember correctly, I could see myself saying those kind of things, but that's not a reason that there are so many things that can be put in people's way to help them.
Yep. Yeah, and I think, so one of the things that has been focused on a little bit during the committee sessions is this question of coercion. But when we're talking here about feeling a burden, it doesn't require any of that external coercion. It can be purely an internal sense, even what might be felt a noble, self-sacrificial sense of, I want to step off the stage, so that I'm not eating into the inheritance, so that I'm not taking time away from my family members and so on. So it's a very subtle thing, and to see it being accepted there in that clip as a valid reason, we really must do better.
You're talking about family there brings us very nicely onto the final clip that I want to show you. This is an assisted suicide doctor, an American, and the question is asked of him about the situation where families try to persuade a loved family member not to go down this road. Let's have a watch.
I was also concerned by what you said about what you call family coercion, I think, which is people trying to stop their relatives taking this option. Is there anything you think we can do to prevent that happening?
Yeah, I think it could be made into a misdemeanor or felony or whatever the equivalent is over there. Sorry, I don't have the terminology. Make it illegal to interfere with a patient's right to make this choice.
Make it illegal for a family member to, say, a son or a daughter, to try and talk their elderly father or terminally ill, I should say, father or mother, out of taking the assisted suicide option.
I think that's so sad actually to hear that, because it's such an instinctive response of a family member to encourage someone not to take their own life. And I suppose I'm thinking of the 1961 Suicide Act. It's illegal to encourage someone or to assist someone to take their own life. And so actually it would be to turn that on its head and say that it was the right thing to do in that situation. So I think that's an interesting legal question. I'm also, I suppose it made me think of the tube adverts. I don't know if you remember, there were adverts on the tube in Westminster around the time of the Leadbeater bill, and in a sense they
talking at second reading now, aren't you? Just ahead of second reading.
Ahead of second reading. Yeah, in some ways they were encouraging people that taking your own life was a positive thing, that was a good thing, and I think many people felt instinctively troubled by that. Because we have, as we've mentioned before, suicide prevention quite complex and important suicide prevention in this country, and I think people felt quite troubled by those adverts. And I remember seeing just a day or two later that there was a Samaritans poster on top of that, and I remember it said that we're here for you, whatever the issue, and I think that to change that whole dynamic of someone being suicidal and not encouraging them to that their life is of value and worth, that they're of value and worth, seems very, very sad and I guess distorted. I don't know what you think, Chelsea.
I couldn't agree more, and the question that always comes to my mind is, what kind of society do we want to live in? What kind of society do we want to live in when someone is expressing, a desire to take their own life? Is it one where they're handed a lethal medication, or is it one where they're given support and care? And I think sometimes it feels like a very abstract idea until it's real for you. So I wonder, if we have this bill that's before Westminster, would if a person with diabetes, type 1 diabetes, were to stop taking insulin and thereby make their irreversible progressive condition, which diabetes is, likely to cause death within 6 months, because of course if they have capacity, you can't have a physician force treatment on them. I'm just imagining a 19-year-old young woman who goes through a very deep depression and maybe has social circumstances, maybe breaks up with a partner and gets into a depression and becomes suicidal and wants an assisted death, goes, this is available, I can qualify, and stops taking her insulin. And I'm just imagining her mother not being able to encourage her to get into mental health treatment, to wave the flag and say, there's something wrong, my daughter's become suicidal. And the idea that mother could be jailed for that's what I just don't think people have really thought these circumstances through. And the same would go for anorexia. The same would go for a young man with HIV. Those are all conditions that could fall within the definition of terminal illness in this bill. And to say that you could be imprisoned for trying to prevent a loved one's suicide I find that shocking.
Dave, the people pushing for this bill have talked an awful lot about compassion, being compassionate, that doing this is the compassionate thing to do. that does not sound compassionate.
No, well, we're back to terminology and lexical engineering, aren't we? That just as the term suicide is being avoided, the word compassion is being redefined. The true compassionate response of the society we all want to see is to care for people in their darkest moments, not to affirm them in their belief that their life is not worth living. We must stand for true compassion.
Mm. And of course, as the Christian Institute, we believe that every human being is made in the image of God and has value and dignity because of that, whether or not they have a terminal illness of any kind. Dave, just a final word from you. Although it passed at second reading, you did touch on this a little bit earlier on, but although it passed at second reading, a significant number of MPs who voted for it there indicated that they would be looking for significant improvements to be made. Is there any sign so far of the committee members really taking on board some of the problems that are raised by Chelsea, other witnesses, people who've articulated the same kind of arguments as Gillian, the psychiatrists raising concerns about capacity and coercion? What are the early signs of them saying, yes, we perhaps have got some things wrong, we need to do something about it?
Well, I think as we've already mentioned, that the most significant change to my mind being proposed at the moment is the dropping of this judicial oversight element. And so in that sense, the bill seems to be moving in the wrong direction from the point of view of those who want to see safeguards added. That seems to be the removal of a safeguard, which I think is causing many MPs to think again. You touched on earlier, really, the evidence that Chelsea brought was rather dismissed by a subsequent witness who talked about just being one or two examples that we shouldn't really focus our attention on. I think, again, as we've said, there's been huge confusion around this issue of capacity versus mental health, and we haven't really bottomed that out. There's a huge weight being put on capacity that the Mental Capacity Act just can't bear. So I don't think we're seeing the additional safeguards that MPs seem to be expecting put in. The bill isn't getting the scrutiny that they expected it to get.
Thanks, Dave. And thank you to Chelsea Roff and to Dr Gillian Wright. Thanks both very much for your time. The important thing to take away from this is that there is still so much to fight for, as you've just heard from what Dave summarised at the end there. Of course, some MPs will be so invested in introducing assisted suicide, they will never admit to the serious dangers of this bill, but many will be open to persuasion, especially from their constituents, which is why it's so important that you take every opportunity to make your views known. Some changed their minds ahead of the vote at second reading because of the influence of their constituents. Others lent their vote to the bill at second reading, but could well vote differently next time round. So make sure you're on our mailing list. We'll contact you at the best times to get their attention and provide you with all the information you need to make the case for scrapping this dangerous bill. Until then, don't forget to like and subscribe to this channel, and thank you for watching.
For more great content, like, subscribe and hit the notification bell.